Hi, everyone. Thanks so much for joining our webinar today. We're about to get started. We're taking you through today the Guide to Infection Prevention, Part 2, where we're going to talk through the use case in hospitals and acute care settings. And I just wanted to let you know today I have the great pleasure of being joined by Bruce Osborne, who is our Director of Environmental Services at Carle Health, and specifically at Carle Foundation Hospital, which is recognized as one of America's 50 best hospitals by Health Grades, and also holds a magnet designation for 3 years running, which is the nation's highest honor for nursing care. So it's my great pleasure to introduce you to Bruce. Bruce, do you want to say hi?
Well, good afternoon, everybody, from beautiful Central Illinois. It's a pleasure to be with you.
And I wanted to just run through our agenda today, and then I'm going to talk a little bit about indoor health and how that has an impact on hospitals. And then largely, most of our conversation today is going to be with Bruce and him sharing about his experience, his environment, use case, and walking through specific examples of how they're using UVC as an effective solution as part of the environmental services team at Carle Health. So introductions we've covered off. We're going to go through the impact of poor indoor health in hospitals, what that means, what the impact of creating a healthy indoor environment can be, infection prevention specifically at Carle Health, as I mentioned, the use cases where Bruce is leveraging UVC as a technology and how that works, what kinds of outcomes they're driving, and then we'll have Q&A. Reminder, please, that you can ask questions at any time. They are being queued up in the side of this webinar, and as we have questions, we can answer them as we go or at the end. Please ask all your questions. If we don't have time to get to any question, we will certainly respond after the webinar. All of this content will be shared with you following the webinar as well. So with that, the impact of poor indoor health in hospitals. So I think what we all have learned over the past few years is that the best of life happens indoors, and it's really critical that our indoor spaces are healthy. We certainly have a vested interest in keeping our kids safe in school and protecting teachers and staff. In those environments, we have a critical need to create healthy environments for our frontline workers, for our loved ones who are receiving care, and all the extended health services that reach our communities in that way. And certainly to the extent that we keep our indoor environments healthy, we are contributing to a thriving economy, which is important to us all. So over the past few years, it's been a reminder that we need to provide healthy indoor environments. Certainly what we learned is that indoor health has gone unchecked for too long. We've paid attention to the quality of our outdoor air without paying as much attention to the quality of our indoor air and indoor environments in general, surfaces and air. And we've realized collectively, I think as a nation and as a world, that infection spreads indoors. And to the extent that we can create a healthy environment, we absolutely should do that. Of course, hospitals and acute care settings have known this for a long time and have been on top of using technology to prevent the spread of infectious disease, but are constantly seeking the best-in-class technologies, methods, processes, even data support and how data supports your organization to enable creating the healthiest indoor environment. What we're talking about mostly today is the spread of air and surface-borne pathogens, how they're transmitted and how they're mitigated, and certainly as an environmental services team, best-in-class practices and approaches to keep that pathogen load as low as possible. Airborne diseases, we've been talking about everything from the common cold to flu, to COVID, to more infectious diseases like tuberculosis, where UVC actually has a strong use case with tuberculosis for many years now, and also the spread of surface-borne pathogens as well. We can get infected by breathing air while sharing space, and often in close proximity. But the longer you're in a space with infected air, it creates an opportunity for risk that's certainly impacted by your own personal immunity, and also by touching contaminated surfaces. And mitigation can include everything from social distancing to airflow and pressure in an environment. Hand washing, manual chemical disinfection are all methods that are used to prevent the spread of infectious disease, as well as UVC, which we're going to be talking about primarily today. So with that brief introduction, I'd like to get into the meat of our conversation, which is really about Bruce sharing his experience at Carle Health and how they came to their current program of maintaining and creating an environment for indoor health, and also their protocols for disinfection. So with that, Bruce, maybe you could tell us a little bit about Carle Health as an organization. I think everyone would be interested to understand the scope of your team and also your organization. And let's start there.
All right. Well, again, good morning / afternoon to everybody. It is a pleasure to share a little bit about my wonderful team and the wonderful place that I call my work home, Carle Health in Urbana, Illinois. The hospital that I am a part of is called Carle Foundation Hospital, and it is licensed for 489 beds. Our average census is about 440 every day. So we're a level 1 trauma center, and we're also a level 3, I believe it is, or level 4 NICU unit. We have a lot of other, we have a cancer center assigned to us. We're also a health system now. Since I have been here for 15 years, we have increased our footprint in hospitals. We now have, I believe, 6 or 7 other hospitals who are now part of Carle Health, and we basically stretch for a wide swath of central Illinois. So Carle has always found itself to be a leader in our area for not only high quality healthcare, but also we're a vertically integrated system. So we also have a med school, we have a nursing school, and we also have a full health insurance company that is all part of Carle Health. So there's a lot of ways that we can touch our community and help our community. But again, it really boils down to, from my perspective as an environmental services director, what are we doing when they get here, and how are we preventing patient B from getting what patient A might have had in their room? When I began,
the scope, Bruce, of your environmental services team, like how big, what are the roles, what is everyone responsible for?
Okay, great. I am the sole director of this institution, and then we handle the clinics and things like that. I have 2 managers, I have about 6 supervisors, and then I have about 6 what we call coordinators. A lot of places call them leads, to kind of be the boots on the ground to help. Our staff then totals about 250 frontline staff members who are the ones that make us all look good, the ones who really are the boots on the ground doing the cleaning and disinfection every day.
Perfect. Okay. So maybe you can tell us a little bit now about what is a day in the life of an environmental services team member. What are you responsible for? What does the daily routine? Maybe let's talk about your responsibilities first, and then let's talk about what a daily routine looks like.
Okay. Really depends on what shift you work, as all my friends in EVS will attest. If you're a day shift housekeeper, your first task is to go into every patient room and do kind of a refresh of the room. Disinfect all of the flat surfaces, the high touch points, as many as you can get to, and interact with that patient, fully clean the restroom. So we try to mitigate the amount of germs that are in that room as best we can while the patient inhabits that. And then there's also the discharge clean. Some people call them terminal cleans. We use the term discharge cleans when the patient is discharged. And that's about a 40 to 45-minute process where we kind of deep clean that room, remove all the visible soil with a hospital grade disinfectant. And that's where we began using the UVC light to complete that part of the project.
Let me ask, I want to ask you about what your state of affairs was before you started using UVC and how that clean actually happened and how long it took and what you're doing now. But before I ask that question, just to give a scope, how many rooms then of the total room of all of your rooms, 489, approaching 500, how many of your rooms do you clean on a daily basis?
Well, every room that is inhabited by a patient, so if we look at our average daily census of about 450, every one of those rooms would receive a daily clean inside that room. And then average discharges per day were anywhere between 150 and 175 average discharges. Some days are 120, some days are 200. That's where we use the more in-depth cleaning process and do that.
Okay, so before you started using UVC as part of your protocol, how would the teams do the daily clean, and then how would the teams do the discharge clean?
With the daily clean, nothing really changed there. We haven't yet got to the point where we're going to be utilizing UVC on the bathroom during a daily clean. We will, depending on the patient's stay length, where if they're going to be in that room for maybe a week or so, we might bring a UV light in and shut the bathroom door and utilize that once or twice during their stay. But if on the discharge clean is where we've utilized UVC extensively. Prior to when I first got here, the 7-step method of cleaning that we all use, that was it. Then about a year or two into my stay here, we had a director who was a very firm believer in the electrostatic spraying technology. And so we started purchasing electrostatic sprayers and putting our chemicals in there and having our EVS technicians on every discharge after they got done with the cleaning, before they would reline the cans and make the bed and do all of those final steps. They would go in with an electrostatic sprayer and they would spray for 5 minutes with the door closed inside that room, the entire bathroom, the entire patient room, bed, curtains, everything inside of that room, in order to create as disinfected an atmosphere or room as we could create. That, because of electrostatic sprayers, it forced us to gown, use respirators, goggles. It forced our EVS techs to spend probably about 15, 20 minutes additional time, 5 or so minutes to get ready, then the 5 minutes of spraying, then the 5 or so minutes to kind of take everything off and get it out of the room. So it did increase our time when it came to those throughput numbers that we were experiencing.
And what was your staff's reaction to electrostatic spraying?
They weren't excited because it was more for them to do. And our folks, like all of the EVS technicians across the way, and all of us, we all work hard. And this was just another step, but they did understand the why. And so we really hit hard that this is going to create an atmosphere that's going to be better for the patients and the families that come next. So they did it, but there were some issues with anytime you spray a chemical in the air, that's never really what that chemical was made to do, especially when you're talking about hospital grade disinfectants.
Okay. And so that was the way the cleaning, part of your cleaning protocol before. What encouraged you to consider an alternate potential cleaning protocol from electrostatic spraying?
Well, I think it really started post-COVID because a lot of things just kind of went on hold, as we all know, during COVID. Everybody was just trying to keep their head above water during those couple of years. But following COVID, um, actually what started it was that director ended up moving on, and we got an interim director who happened to have a nursing background. And so I started talking to her about the beauty of UVC. One of the things that I've always been intrigued with UVC was the cleanness, maybe the greenness of the not only the machine itself, but also the fact that when you're done, we're not really changing anything. We're not putting more chemicals in the air. It's very green, and so that was a big thing for me personally. But also when I started doing my research within the last few years, what I found is when I first started researching this 12 years ago, the companies were few and far between who manufactured good quality UV light machines. Therefore, it was very expensive to purchase one. And I knew with a hospital our size, if they're going to work, we needed to have multiple machines in multiple locations to make it very easy for our staff to get a hand on one, get it in the room, and utilize it. And so that's when we began doing our research with UV, and we found our zero as a company, and we've been working with them ever since.
And when you talk about now, so you decided, tell me the reasons why you decided UVC. Like, what were the critical factors in your purchase decision?
I think for me, it all boiled down to safety. I take my role as director seriously in the sense of it's my job to protect not only our patients, not only our families, not only our visitors, but also the employees that we have. In the past, because of a lot of maybe we'll just say health conditions of various people, anytime you spray anything in the air, it can cause discomfort to a certain amount of people. I wanted to stop that. And what a beautiful alternative to simply use light to do a better job of what we were trying to do with spraying chemicals in the air. And that to me was really the determining factor. It wasn't price, it wasn't all of the other things that are, while very important, for me, it all boiled down to safety. Safety, of course, first and foremost for our patients and families, but then also it was a very safe alternative to the spraying of chemicals for our staff members themselves.
And who did you bring into the buying decision? Like, who did you have to influence in your organization to approve moving forward with UVC as part of your core disinfection protocol?
Well, as many of us have probably dealt with before, it's easy to convince one person, but it's much harder to convince a group. So what I did is from the very beginning, I chose a committee that included facilities, IT, infection prevention, logistics, nursing managers, as well as environmental services people as well. And we looked at 3 or 4 different companies. All we looked at many more, but then I should say we invited 3 or 4 to come in and actually give a presentation on their machine. And so we walked through all of that, and then together we made a decision on which company we liked. And then I have the great honor, my one-up, as we call them here at Carle, happened to be the president of the hospital. And so I had the great benefit of being able to report directly to her. And she was, once I shared with her all the documentation, not just about pricing, but about safety, she was on board. We got it set up. And about 3 or 4 years ago, we purchased our first 5 machines. And we've been utilizing them in our operating rooms, our oncology unit, and some of our med surge floors where we have a lot of what they call turn and burn, a lot of turnover. we've been using them there for close to 5 years now.
And what does that process look like? So can you tell us now that you've moved away from electrostatic spraying and you're using UVC as part of your disinfection protocol, can you talk about the different ways in which you use it and the benefit? Like, does it save you time in any way, or sort of the outcome that's happening in each use case where you have it? So maybe you could talk about like an operating room example, and also when you're doing a discharge, for example, how does UVC play a factor in your protocol today?
You bet. With our operating rooms, we've seen a good increase in the productivity of our staff with UVC versus spraying. And the reason I say that is you never know how much spray to put down. You never know, did the timer go off? Did I not hear the timer? We also happen to, at Carle, we have two hearing impaired people who pair up and work in our operating room together. Well, spraying and hearing an alarm isn't going to help them. So the lighting on the UVC at the top that signals what color means what was very advantageous for us, and it created a much safer environment for them. When it comes to an operating room, we don't really see a change in any of the cleaning protocols other than there are 3 locations in most rooms where we place the UVC, and we put it on its cycle for either 3 or 7 minutes, depending on the distance, of course, from the wall or other items in the operating room. And then some of our operating rooms are a little smaller, so we can get by with 2. So we haven't really seen a increase or decrease in any timing there. When it comes to our patient rooms, we did change our 7-step method a little bit, where after the stripping and the high dusting, all of the things we normally do at first, we fully clean the bathroom at that point. And then we put the UV light in there and treat it for 3 minutes, because all our bathrooms are relatively small inside the patient rooms. So we treat the bathroom for the 3-minute cycle while we're finishing cleaning up the rest of the room. Then when that ends, we finish up the work we need to do in the patient room. We wheel the light out, and then we place it in the 1 or 2 locations inside the patient room, operate the cycle. While the cycle is going on, because the person is not to be in the room, that gives them the opportunity to go empty their X cards from their trash, their linen, and their bio. Gives them the opportunity to go get a sharps container if they need to change it. Also gives them the opportunity to go get the clean linen, so it hasn't been placed either on their dirty cards or inside the dirty room before it's been treated. So we just found a way to utilize the UV, so we're kind of doing 2 things at once. So it's made us much more efficient in the end.
And how much time do you think that saves the team?
We probably save, I would say, about 5 minutes a room. And while that doesn't sound like a lot, when you consider 150 discharges a day, that's 750 minutes. We've saved, 12 hours of time or more. So it really does make us more efficient. We find we're having less beds left over on the end of the night, turned over the next morning, that we just didn't have enough time or people to clean them all. We find those numbers are much smaller than they were previously.
Are there any other savings, like chemical cleaning, chemical savings, or other savings that you've experienced?
Oh yeah, we've probably saved about 15 to 20% in our chemical costs, because we're no longer filling those sprayers up. And as we all know, nobody just wants to put a little in anything. We always got to fill it up to the top. But then within 24 hours, you got to dump all that out and refill it again. So we've seen a lot less waste, a lot less usage of water. And then, of course, just the sheer usage of chemical has gone down.
Do you connect your disinfection protocol at all to energy savings or sustainability initiatives in any way?
That's not really my wheelhouse on this. We are working on that. We are now, I believe, going to be embarking on on some green health initiatives, things like that. I'm not sure about the electricity thing. I don't have any of those numbers kind of with me, but I can safely say less water, less chemical.
Okay. What about how you use data today? So, are you using data to help you understand disinfection status from using UVC, or receiving reports that help you on a daily basis, or a weekly basis, or a monthly basis to understand efficiency, effectiveness?
Yes, good question. That was actually one of the things that was foundational for us in our decision to utilize our zero for UVC. Um, Again, I can't speak to what all the other companies do. I can just speak to what we saw. Our zero's platform of getting data is nothing short of remarkable to me. Um, I can find any machine at any moment, tell you the last time down to the second that it was turned on, how long it was for, and what room it happened to be in. It is a great platform, and it makes my life really easy when I'm questioned to say, hey, room 21, 2105 was a C. diff room. I want to verify that it was treated with UV light. I can easily go to the dashboard, find that room, tell them exactly where it was, exactly what time it was treated, and how long the cycle was. So that platform has been a real godsend in a sense for us because it made my life a whole lot easier for research on disinfection protocols.
How is I asked you about your staff reaction to electrostatic spraying. What is your staff reaction to using UVC? Environmental services team members, as well as like that overall buying committee that you worked with?
Infection prevention was ecstatic to move away from electrostatic spraying to UVC. They had always been a proponent of UVC, but previous to myself becoming the director, there seemed to be um, a little I don't want to say animosity. That's not the right word, but a little competition between infection prevention and EVS. Who was going to get their way? Now we work very much hand in hand, very much as a team, and it's been a wonderful couple of years to utilize UVC to the extent that we are now. Our staff, literally, when we announced we were going to stop spraying and begin using UV light, we brought them in. We have EVS staff meetings for our entire staff every quarter. When I did that, everyone stood up and clapped. They were so thankful to not have to spray those chemicals in the air anymore, not have to breathe all of that in, not have to gown up like a stormtrooper on Star Wars in order to finish the job. They understood the why. They knew we still needed to do something in order to give that next patient as clean an atmosphere as possible. But that new UV light was so much safer and so much easier to use than spraying. And they even came up with the idea that if anyone has ever used UV light before in an area, there is a slight smell that comes from a UV light after it's done, and they just simply call that, well, that smells clean, because they know what UV does, and so they've drawn that akin to that smell equals clean now.
Excellent. As you think about disinfection protocols in the future, use of UVC, do you have plans to expand the use cases or other thoughts about how you'll use data to extract insights that are meaningful to your organization and understanding disinfection status?
Oh, very much so. Our plan right now is we have just recently purchased 25 more ARC machines, and they are in the process of getting set up and programmed for each individual unit of this hospital. So as right now, we're using them in key areas and isolation rooms. The eventual goal is to have every discharge room treated with UV light. Then, and every OR every night treated with UV light. Every cath lab every night treated with UV light. And as the data begins to then show what we all hope for, lower infection rates, lower length of stay, all of those sorts of things, then we're already in conversations with our sterile processing department in utilizing some of the other UVC technology. I believe the items are called, it's like a far UV. I think there's a product called a Beam and maybe a product called a Vibe are the two that are there. So trying to utilize those in our SPD, maybe in waiting rooms, some things like that, in order to keep everyone safer, not just those patients who are inside the room, but utilizing them in other key areas, lobbies, waiting areas, things like that, in order to protect our community.
Excellent. And when you report up metrics to your organization, like, are there one or two key metrics that you use from data, disinfection data that you receive, that helps you, demonstrate effectiveness to your key stakeholders?
Yeah, infection prevention does, of course, most of those reports and things like that. But the one that they are most concerned on right now is, I believe they're called site infections in operating rooms. And especially in like orthopedic cases, things like that. They are very susceptible, I guess, to surgical site infections. And that is something that they are looking at. And then that could also expand that use, because we also have 2 or 3 surgery centers apart from Carle Foundation Hospital. And then the goal would be then, if we see a reduction in surgical site infections here at the hospital, we can also utilize UVC then in those other areas as well.
Wonderful. We have a question in the chat, which is, how have patients and families responded to your use of UVC? Are they aware of it? Do they comment on it or ask questions?
Yeah, they have. Mainly they ask when their neighbor, we'll call them, from the room next door, leaves, and then they see somebody wheeling this very large white machine down. And so they ask questions. So we've trained our staff, hey, stop, give them 2 minutes, talk to them about it, let them know what we do, and then that'll make them feel even more at peace when they have to come back, because they know, oh, look, this room is being treated not only with the mechanical process, and I assure them, no people are being replaced with any of this. This is all in addition to our wonderful staff members that we have who do the mechanical cleaning process. As we wheel these on the elevators, as we place them throughout the hospital, we always have at least 3 or 4 people comment on, hey, is that one of those UV light machines I saw in the newspaper? So yeah, we had a nice press release. Our Zero and our marketing department got together, worked on a very nice press release to get that taken care of for our communities. So they know this UV light thing is here to stay here at Carle. And the whole point is healthier people, healthier communities.
Excellent. Thank you so much. We have another great question in the chat, which is, what is your role in the hospital's water management plan in terms of preventing Legionella? And what steps specifically are your team taking to prevent it? What steps does your team take to prevent it?
For EVS, our facilities department actually owns the Legionella issue. Our role is upon every discharge, it's not great water management, but it's what we have to do in order to clear those loops. We run the shower while we're cleaning it. Meanwhile, while we're cleaning the rest of the bathroom, I guess I should be a little more specific. In order to get about a 4 to 5 minute run, in order to clean out those loops where the water sits, where Legionella can be. And then we also then, on any shower that has a handheld shower, we leave that hang so that water drains out, so nothing sits in there. We flush lines on a regular basis. Our facilities department does most of the testing, or all of the testing, for that in our facilities here.
Okay, excellent. Thank you. And then another question in the chat: how did you train your team how to use UVC disinfection towers?
Another excellent question. First and foremost, R0. They have a great training program, a great video that they can watch online, and then they get emailed to them a certificate. And our staff love certificates. And it comes with their name, because you kind of log in to R0 and it comes with their name printed on it. That means the world to our folks. So that was very important. Then from there, we know we've got to take it the next step. Practically, how are we using them here at Carle? So then we as leaders, I have personally trained every leader here at Carle Health in the EVS department on where to plug it in, how to plug it in, how to unplug it. You don't grab the cord, you grab the plug. All of the little ins and outs, how to lock the wheels, how to change the bulbs, all of the ins and outs, which are all really easy, but we want to make sure everyone feels comfortable with this. Because if you're not comfortable with it, odds are you're not going to use it correctly. So we want them to, in a sense, have a relationship almost with the UV light machine. That's why we store one on every unit of the hospital. It becomes part of their infection prevention gear, not just their microfiber wipes, not just their microfiber mops, not just their disinfectant. That ARC machine becomes part of the family, and they take it with them on that discharge. And so they feel very comfortable with them. They know I got to hang my sign to keep everybody else out. And they also are trained very well to know you don't enter that room unless it's an emergency, even though there's all of those safety precautions that are built in. We want to be very, very careful with that. We want to treat that technology with respect.
Excellent. Is there anything else that you would share with hospitals that are considering adding UVC to part of their discharge routine or their daily cleaning routine?
I guess I would recommend you start with, first of all, find the right company that fits your goals and ideals. For Carle, that was R0. We fit very, very well together. And to be bold, I'd encourage you to look at R0, please, just to give them an opportunity, and maybe you'll feel the same way that I did in working with them. But you don't have to buy 25 of them or 30 of them at your first order. Start with a couple and use them in places where infection prevention says we're having issues. When we started, we simply bought 5. 2 of them ended up in the ORs, and all they did was orthopedic surgical suites. That's it. But we saw results that led us to understand this technology is working. Therefore, that order of 5 turned into an order of 25 about 18 months later.
Excellent. Thank you so much, Bruce, for your time today. We so appreciate you sharing your story with other hospitals and also other acute care settings that might be considering using UVC as part of their disinfection protocol. It's really great always to hear from your peers. I think that's the most useful information. And we're happy to share this story broadly with everyone who joined us today and who registered for this webinar. And I'm sure we'll have opportunities in the future to share your success as you expand your program of UVC as well.
Love to. Thank you very much. It was a pleasure to be here today.
Thank you so much.